Okay, guys, so I'm not going to rehash a lot of the last lecture. In fact, I'm probably not going to rehash any of the last lecture, but I'll rehash a little bit. I talked about how these things are placed, which is kind of indicative of this slide. Here's sort of the anatomy, right? So I'm putting a needle into the epidural space, I'm threading a catheter in there, and then we're hooking that up to an infusion. There's an image of kind of the catheter. We went through benefits and just kind of side effects of an epidural. I'm pretty sure we landed here last time on complications. So let's just dive right in to some of the problems we can experience with an epidural. Here's a pretty decently common one. Either an inadequate epidural or a failed epidural. So this usually ends up with at least pretty patchy analgesia. You can have some missed dermatomes, meaning that like I'm numb up here, but I'm not numb here. And hopefully they're patchy in an area that doesn't matter and not their surgical site, right? You can have an inadequate density of the blockade. That's much less common, just because the concentration of local that we use is pretty good at blocking just pain. Excuse me. A bunch of patients sometimes misinterpret the signals as I can feel something, therefore I can feel pain. That's not really how your nerves really work. You can still have a lot of, not a lot of, but some sensory input, right? Like I know you're touching here, but I can't really feel it, and it's real vague as to where you're touching, that sort of stuff. So, like I said, that one's less common. And then I've had epidurals, I put them in, they felt great. These patients don't get any blockade from it, and you redo it. So that's another complication. I'm like yawning a bunch today. What the hell? Okay. Another complication. This one's pretty bad. An inadvertent spinal or a high spinal. So let's say I'm placing an epidural for, rib fractures or something like that. I go in, I place the epidural. Everything seems fine. We give afterwards what's called a test dose, right? So I'm going to give you a little bit of local and see where life takes us. If I give that little bit of local and you get a profoundly dense block from that small amount of local, chances are I'm intrathecal. I've actually gone through the dura into the actual spinal column. So that's not what I want. If you give like the epidural dose directly into like the CSF, you will produce a super high block. And by high, I mean dermatomally. Like it will creep its way up into your brainstem. Why is that bad? Because the brainstem controls a lot of your vital functions, like breathing. So in these patients, they get either an inadvertent spinal in itself isn't necessarily that bad as long as it's recognized early. I can actually thread a catheter and make it an intrathecal catheter and run that. I just have to run super low doses. Patients that get this, let's just talk about like OB, right? So patients that get actually have an intrathecal catheter are going to have like the super dense block, and they're very comfortable as long as they're not like OD'd with it or anything. It's like I said, it's a super dense block that patients sometimes really enjoy because they feel nothing. A high spinal is what I was talking about earlier. It's where I inject a bunch of medicine, somehow or another, it goes way up high in your CSF, gets up in your brainstem, and so what is that going to look like? Well, usually it's pretty rapid. It's kind of an ascending block, so patients will start to have, I can't feel my trunk, I can't feel my arms, and then they're going to say they have trouble breathing, and then they're probably just going to go unconscious. When you numb up the brainstem, usually you end up completely passing out. So that's not good for those reasons. Yes, you'll get bradycardia because you've numbed up your whole sympathetic chain. Hypotension, same reason. Difficulty swallowing, difficulty phonating. Any patient that you see with that has an epidural, you need to really question whether or not they're having a really bad block. The treatment for this is time, right? I'm not going to give them any more of that local. I'm not going to run the infusion. The first thing you do with these patients is to stop the infusion. I never know how to say this. A lot of people say pruritus. I think the correct term is pruritus. Itis means inflammation, so I don't know why that would be a thing, but whatever. Common side effect from most of the time, everybody's running epidurals with some little bit of narcotic in it, and you're running that little bit of narcotic right next to its receptors, and so you will still have some absorption of narcotics and some side effects, right? So this is like the most common side effect of having either an epidural or a spinal. More common with spinals than epidurals if you add narcotic directly in there. You're also adding a bunch more usually if you're putting it in the spine because you're not leaving it like as a constant infusion. So the thing to note on this, and we always do this and it does kind of drive me nuts, is it's not mediated by histamine release. You should not have histamine release like with an epidural. You should not have a lot of flushing and all that stuff. This is centrally mediated itching caused by the mu receptor, opiate receptor. So the only thing that should take that away is something that will completely reverse that receptor. Basically meaning you're going to have some reversal of that narcotic. So the treatment is naloxone, which is an antagonist, naltrexone, which is an antagonist. Nalbuphine is kind of we don't use it a lot here, but it's kind of a common drug you'd see over in OB. It's an agonist-antagonist, meaning that it has kind of a ceiling effect. So for whatever reason, it's hard to overdose because you saturate it at kind of a 50% level. But anyways, that will help take away some of the itching. You can give Benadryl. Some patients say they feel better. They're liars. They don't really, it's a placebo thing because that's been studied and that's not fixing the issue. The issue is actually the opiate mu receptor. And there's been a lot of research as to how what drug can we use to make itching better, but still keep that pain like relief. And no one's figured that out yet. I think we're somehow close, but nobody's figured it out. Nerve injury. Everybody asks me that I'm doing an epidural on, like what gets damaged. I tell patients they can have damage. I've still never really seen true blue damage. The numbers I found were about 1.5 in 100,000 epidurals, like so super uncommon. It is apparently even more rare in OB patients, don't know why. But it's super rare. Paresthesias, meaning that during placement, I may bump up next to nerves and things like that. The needles that we use to place epidurals are called TUI needles. They're kind of smoothed at the edge. They kind of have this bevel that kind of curves up. But what I'm saying is they're not super sharp, and so you're really going to have to plow through a nerve to hurt it. And you don't make big movements when you're doing it anyways. And so patients will let you know if you're rubbing up against nerve because it's not comfortable. But the incidence of actual damage is pretty low. But patients will have these paresthesias. Oh, I just felt like a weird tingle down my leg or something like that. That happens pretty often. And then something basically said 0.1% can have persistent paresthesias post-operatively. But I guess these get better, or else we would classify them as a nerve injury, and then that's 1.5 in 100,000. So you can have paresthesia. Yes, your nerves do undergo some healing and things like that. The hardest part of this whole thing is that I'm putting this in blind, right? I don't really know where I'm pointing at and things like that. So that can make it a little difficult. Here's another fun myth that I've heard all the time. Epidurals cause back pain. I went and had a baby naturally, and I didn't have back pain afterwards. I went and had a baby and got an epidural, and my back has hurt for years. It was the damned epidural that did it. There is currently no evidence that supports neuroaxial procedures resulting in long-term backache for the majority of people outside of a documented thing, right? Now, I will say this, when you place an epidural, there's going to be some scarring, right? I am passing a pretty good sized needle through your back, through all those ligaments and things. I'm disrupting tissue. That's going to have a certain amount of healing to it. There's probably going to be a little bit of bleeding, especially in parturients, in the OB population. Your epidural veins, like the baby's sitting on your inferior vena cava, and so your blood needs to get back to the heart somehow, and for whatever reason, sometimes the best way to do it is right through your epidural area. So pregnant women's epidural veins can get really big. It's kind of weird and also kind of disheartening when you're trying to place an epidural and blood just kind of goes everywhere. It can make it hard to place because, again, I'm using that loss resistance technique and there's not going to be a lot of resistance in a vein. So sometimes that can be an issue, but for the most part, there's a lot of different things that go on during labor specifically that can cause long-term back pain. So I put in here this study that I found on UpToDate. There were 600 parturients. They were assigned to either epidurals or meperidine, which probably means it's a really old study because nobody uses, that's Demerol, for those of you that remember what Demerol is. We occasionally still use it. So there was no difference in postpartum back pain 6 months out. Both of those study arms had long-term back pain. So it's more the act of, shoving a baby out of your body, which we won't get into here. So that's that. I need to quit touching my mouse. The mouse wheel apparently advances these slides, and that's why it's freaking out every time I touch my mouse. Okay, post-dural puncture headaches. These suck so bad. If you've ever had to take care of if you've ever had one, I'm very sorry, because it looks miserable. If you've ever taken care of a patient who's had one of these, you'll kind of see the gravity of it. So what is this? This is when I'm placing usually an epidural, and I accidentally puncture through the dura into the CSF. And that causes CSF to leak out, and these fibers that are part of the dura go longitudinally, right? So from head to, from cephalad to caudad, these kind of go up and down. And so you disrupt these with a spinal needle, which is usually much smaller, and pencil point. It shouldn't be real sharp. So it actually is parting those fibers open, and you're accessing like between the fibers, and then it comes back. And that's been shown to cause less of this. When you're doing an epidural and you happen to bust through, that's a huge needle all of a sudden. And so you're disrupting a lot more fibers. And so I think the incidence of post-dural puncture headache is actually higher with an epidural, if you accidentally puncture the dura, than with a spinal where you're definitely puncturing the dura. Doesn't make a lot of sense there, but I'm pretty sure that's true. So it usually occurs within 6 to 72 hours after having that dural puncture. After you disrupt those fibers, they should heal back, right? Things that that are constantly being disrupted don't heal wonderfully. So if you have a pretty steady CSF leak through there, those fibers are never going to have the chance to adhere back together and form that bridge. So that's what you run into with like this post-dural puncture headache, is that you have this consistent, persistent drop in your CSF volume. Some people have it for a short amount of time. It heals, it goes away, never see it again. Some people need help. The symptoms of this are anytime your head is above your heart, your head hurts like hell, because you've got this low pressure system in your spinal column all of a sudden. And so when you sit up, your brain will sag a little bit and pull on your meninges. Yeah, and that hurts. That causes a doozy of a headache when you have all this stuff kind of pulling your brain down just a little bit. And so what can we do to kind of fix, I put on here symptoms. People get real nauseated with it. There's a doozy of a headache. You can have visual changes. You can have neck stiffness. Sounds a lot like meningitis, right? Except you have very recently had this incidence happen. Do I have to have a documented dural puncture? Like, do I have to go, oh, I definitely got CSF back? Absolutely not. It can be super subtle to where I'm placing an epidural. I have no idea it happened. And you can still have this issue. So what do we do about it? The gold standard treatment for this is called a blood patch. A blood patch, for those of you that don't know, that's where I take an epidural needle, I do an epidural basically, I access that epidural area, we draw a bunch of blood off the patient, and I inject that blood directly into their epidural space. Why would I want to do that? Once I put a bunch of blood in there, it will start to clot, and it will form a big fibrin patch, a la flex tape or whatever, flex seal, over that CSF leak, and that will help it heal. The best thing we have for post-dural puncture headache is a blood patch. Some patients don't want to do a blood patch. There are risks associated with that. So sometimes we'll start with things like caffeine has been shown to help with this. Different analgesics, obviously. Aggressive IV hydration will produce more CSF. There are certain medicines out there that'll temporarily kind of produce more CSF. I don't remember reading necessarily about like how perfect that works and everything, but blood patch works really well. I think after one blood patch, it's like 75% cure rate, and then after two, it's like 95%. I'm not real specific on those numbers, but it's pretty good. But sometimes you have to do it twice. Yeah, so that's that. Urinary retention, I mentioned, is kind of a side effect, but when it gets dangerous, that becomes more of a pathologic complication of an epidural. It's usually low, right? S2 to S4 is what really drives that whole urinary retention issue. That blocks different afferent and efferent signals to the bladder. Bladder just keeps growing. That big mass that you form kind of in your pelvis will make everything hurt. PACU nurses know if a patient's got to pee and they can't pee, they hurt like hell. It is not a pleasant feeling. So the duration of the urinary retention is directly related to the duration of the neuraxial analgesia. Spinals cause this more than epidurals. Why? Because a spinal anesthetic will drift down. A spinal, the local that we use is usually hyperbaric, meaning that it sinks. And so when you kind of cut off, when you place a spinal and you produce that real dense block, it's all the way down into the sacrum. And so that's why you have that problem more than with epidurals, which is just kind of a spread from wherever you put in the catheter. So a lot of times with epidurals, this is spared, but not always. Each patient that has an ongoing epidural should be independently evaluated for this. So kind of nurse's suspicion, right? If you haven't had urine output for a while and someone that doesn't have a Foley, obviously if they have a Foley, this is a moot point, but you kind of monitor the urine output. If that takes a dive, maybe get a bladder scan, see if they have anything in their bladder, check the patient's comfort, place a Foley if you need it, that sort of thing. Is kind of how to get around this. This isn't a huge issue. It's temporarily a huge issue. Once the neuraxial analgesia or anesthesia wears off, once you stop the epidural, you got like an hour left of like analgesia, it goes away. It's reversible, right? This is just local anesthetic at that S2 to S4. So it'll turn off. You just kind of have to do something in the meantime. Local anesthetic systemic toxicity. I'm not going to go huge into this. This is actually going to be my next lecture topic that Amanda wanted me to talk about. So I'm going to be doing a much bigger, my next lecture is going to be like for the whole OR staff, I think. But anyways, this can happen. Epidurals, much more than with spinals. Spinals, I'm given a real small amount of a local that's real dense, like local. Epidurals, I'm giving a large volume of more dilute local, but still I'm going to keep giving it, and that's why you run into toxicity with that. You can also get toxicity from just regional nerve blocks, but that's a whole different discussion that we'll get to next month. So this is pretty uncommon. I have never personally seen it. We have had a case here, not even that long ago, a couple of years ago, I think, that we highly suspected this is what was going on. But what is this? This is just inadvertent intravenous injection of local anesthetics. So the toxicity kind of has to come from too much local going all over your body. Minor symptoms of this, if let's say I place an epidural, I'm going to give that test dose, right, to kind of see where that epidural is. It's either in the epidural space, it's beyond the epidural space, in the CSF, which can cause a high spinal, right? Or it's in either a vein or probably not an artery, but usually a vein. So if I inject that test dose and a patient immediately says that they have numbness in their lips and it kind of tastes, they have this metallic taste in their mouth, their ears will ring. Sometimes you can have facial like twitching because of like different things getting anesthetized, but not completely. That could be an indication. In fact, that's usually an indication that I'm injecting into a vessel. Now you would think that if the catheter tip of this epidural is going directly into a vessel, then I can aspirate blood from it. And sometimes you can. Sometimes you get frank blood just pull back. It's not good. Sometimes you get just a little whiff of blood and that's it. But as you're placing an epidural, you get a little bit of bleeding into the epidural space anyways. I mean, you're going through tissue. So a little bit of blood isn't really that weird. So that's why we do this test dose. So is the patient toxic from that test dose? No, but it's just letting you know where that is. So if I were to keep giving local, right, keep giving that local anesthetic in there, you will eventually advance to more major symptoms. You can have seizures, right, because I'm numbing up inhibitory neurons in the brain and all you have left is these excitatory neurons. You have a big fat seizure and everybody hates you. Coma. If I numb up everything in your brain, it all goes to sleep, and so do you. You go into a coma. Severe hypotension, yes, because you've anesthetized a lot of your spine and your sympathetic chain, and you're just disconnecting all sorts of stuff. Arrhythmias and asystole is the end game. That's what kills you out of this whole thing. If you go into a coma and you quit breathing, I can breathe for you. If your heart stops, and why does your heart stop? Well, all of the heart's conduction is electrical activity. Local just inhibits sodium channels and electrical activity. Well, there's a hell of a lot of sodium channels in your heart. So it will stop just entirely, but not all at once. You will have a lot of arrhythmias and just weird stuff go on right before it stops. And then you're doing CPR. Well, if I'm using bupivacaine, which is a long-acting local, you're going to be doing CPR for like an hour, maybe longer, depending on how much you got, right? If you got a ton, you're going to be doing CPR for a long time. So honestly, the best mechanical way to get around that is to cannulate and go on cardiopulmonary bypass. This will all reverse, but how can we get it to reverse quicker with medicine? So wouldn't it be great if we can inject something that binds up that local anesthetic and causes that to suck all the local out of your body? We do. It's called intralipid. What is intralipid? Intralipid is just lipid. Like there's nothing really that sexy about it. Turns out local anesthetic, pretty much any local anesthetic, if you put it up next to a lot of lipid, it'll bind with lipid and inactivate. So that's what you end up doing for these patients. If you're doing CPR and all this stuff, the key is to get this bag, which looks like milk, and it usually comes in a weird little, remember those milk bags we had like in elementary school? Maybe it was just me, but they got tired of like milk cartons, and so they have this weird looking breast implant just full of milk, and you stab a straw into it. That's what this looks like. Okay, maybe it was just me. But anyways, that's what they have. It's called Intralipid. That's kind of the brand name for it. The problem is if you're going to a Pyxis, type in Intralipid, it may not pull up anything. So it may just be called It may just be called lipid emulsion, but either way, you give that. I'm not going to get into the dosing now. I'll get into dosing at the next thing, or at the next lecture. But you just give it. Don't even worry about dosing. Like, just give it. We'll figure out dosing. So it should be in the Pyxis. It should be. It should be anywhere you're doing blocks. If it's not, that's a big hole we need to fill, because that's the only thing that's going to save their life at that point. So, to be continued. Spinal epidural hematoma. Like I said, when you're placing anything neuraxial, especially in OB patients, you're going to have some bleeding back there. Bleeding in itself is not a big problem in the epidural space. It's when you keep bleeding into the epidural space and it causes tension. It causes a mass that pushes against the spinal column. So, patients get pressure sores, right? If I just lay my finger right here on my arm and I sit here for 3 days, the point where I'm pressing at is going to get pressure necrosis, right? Because the little white dot, the blanching, that is blood leaving that area because you're pushing it out of the way. Same sort of thing happens with an epidural hematoma. You've got bleeding into this closed space. And as you keep bleeding, you're pushing against the spinal column and you're making it ischemic. That's the big issue. So, like I said, you've got to bleed enough to start causing symptoms. So we kind of get tipped off on this by symptoms. If you were to take patients that have just gotten an epidural, somehow or another take them to an MRI and look at their spinal column, I bet you a lot of them are going to have some bleeding in there. It's just going to happen. But it's when that bleeding doesn't stop and it keeps going and it keeps going and it keeps going. And so that's going to be the issue. So when you get the compression and ischemia, you've got just a few hours. Like, I don't know, it's usually like, it's like 6 hours. So it's long enough to find it and do something about it. But if any patient starts to have these ischemic symptoms of like an uncontrolled crazy block, you stop the epidural, it persists, there will usually be some pain associated with it, that kind of stuff. Any patients that start exhibiting those symptoms, neurosurgical consult, MRI, pull the epidural. Almost all epidural catheters I don't think are MRI compatible anyways. I don't think you can see this on CT. I would have to get back to you on that. I don't remember if you can see it on CT or not. But the gold standard is get an MRI, look at that, get them to the OR, decompress them. Do a laminectomy, pull the lamin off, allow that blood to get out, repair what's bleeding, fix them. I think after the 6 hour mark is when it really starts to like fall off and decline in terms of like successful recovery. So that blows. Don't do it. It's pretty rare. 1 in 18,000 to 1 in 158,000. That's a really wide margin. I don't know why my sources said that. No, they're accurate numbers, but it's just like, depending on which study you look at, it's still pretty rare. I've, luckily, knock on wood, I've never seen it. Yes, it happens more with epidurals. Again, the needle size is way bigger. Yes. Infection's bad as well. We do this as a sterile procedure because we don't want to introduce infection to this very highly sensitive area, right? And for the most part, we don't. Most infections have to do with epidurals that stay in for an exceptional amount of time, or in someone that's immunosuppressed or something like that. So if you develop an epidural abscess, that means you've got bacteria all back in there, and they eat away at neural tissue like crazy. And they make things fragile, and so you'll have bleeds into that area, and maybe you'll have CSF leaks and all this stuff. So not good. You have back pain. You're going to have a fever. Some people get bacteremic, and that's how you figure it out, and you can't find the source of the bacteremia. You'll end up looking in their back, and that's where it is. But a lot of patients will start pointing to that. Again, back pain, headache, erythema around where you place the epidural is always bad. If I'm rounding on a patient that has an epidural in place and it's getting real red around the epidural site, pull it. A superficial infection, that's fine. I can treat that. Don't let it get deeper. These patients will end up having permanent neurological loss from at that site and below. Now, epidural abscesses can occur outside of an epidural. They don't actually have to be, you don't have to introduce something in there for you to get bacteria seated there. Some patients come in with just spontaneous epidural abscesses. They're usually really frail and really sick, but that can happen. And yeah, it just destroys you forever. First off, it takes forever to get rid of for some reason. You got to be on antibiotics forever to get rid of an epidural abscess. A lot of times you got to go have an IND where they kind of open up your back, take out a bunch of lamina, and just get in there and wash all that stuff out. But it typically is pretty devastating. You're sick for a long period of time and may never recover. So that sucks. Let's avoid that as well. Oh, I flipped backwards. So yeah, treatment needs to be immediate. So that was it for complications. Any questions thus far on that huge list of complications? Again, they're pretty rare, but they do happen. So I'm just briefly going to talk about local anesthetics. We don't really need to get into all the science of it and everything, but local anesthetics by themselves are non-opiate means of pain relief. Like I said, they inhibit sodium channels. Your nerves all run on sodium channels, so the nerve quits successfully firing, and that's how you get nerve dysfunction, whether it's numbness, whether it's a motor block, whether it's sympathetics. Something gets turned off. Dosing for an epidural is usually height-based for spread. It can also be weight-based, and both height-based and weight-based plans are typically more pediatric. For adults, you just kind of go this, and they're pretty standard. If you're doing a thoracic epidural, a lot of people start at either 6 or 8 mLs an hour. A lumbar is a bigger space, so we use bigger numbers. 10, 12, 14, somewhere around there would be kind of a rate for that. Adjuncts. We usually don't use local anesthetics all by themselves. Why? Because we can get superior pain relief by mixing some other stuff in there. So we call those adjuncts. What are different adjuncts we can use? A lot of times people use fentanyl. It has a short duration of action, works real good in an infusion capacity because you're gonna metabolize it about as fast as you can infuse it. Some people use hydromorphone. You do run into some issues of it lasting a little bit longer. Whether that's bad or not just depends on how you're using it. Clonidine is another thing. That's an alpha-2 agonist. That actually, Precedex is another drug that's kind of in that category. That helps out with pain. Can drop your blood pressure a little bit, but it does help out really good with pain. So the whole why are we going to use adjuncts? The whole reason we do it is because it works synergistically, which, to refresh you on what synergy means, synergy is 1 + 1 = 3, right? That is where two things come together and produce something greater than the sum of their parts. So this allows you to reduce the dosing for not just one, but both of those drugs. You typically get less of a motor block, and depending on what you use, if you're using less local, you get less hypotension. Again, clonidine's kind of an exception there. We've looked at all sorts of weird stuff. People put ketamine in there because people like to use ketamine for all sorts of weird issues. There's a lot of different things. Toradol, I've heard used. But most people stick to kind of fentanyl and Dilaudid. That's your two more common ones. Here's what our infusion pumps look like here. This is a Sapphire pump. I don't know if it got bought and it's changed names, but I remember them being made by Sapphire. So these are not the same as IV pumps. These are very different. So they have different tubing and they have different ways of delivering fluid through that tubing. So most of these come with a lock box. If you put narcotics in a local, you have to keep it locked up per CMS, JCO, etc. You can't just have narcotic hanging out in the patient's room, even though it's really low. The kind that we use here is typically The local itself will be like 0.1% bupivacaine, and the narcotic that's in it, I think we use 2 mics per ml of fentanyl. That's nothing. That's really low. Again, you don't need a whole lot of fentanyl. You don't need a big concentration if you're giving it directly into the spine to actually produce that analgesia. So it's not typically a big deal. But anyways, it's got to be locked up, right? And the settings also have to be somewhat difficult so that patients can't go and mess with it. So we have a code usually that locks people out of stuff. There's different types of infusions you can do. I can set up a dummy continuous infusion where it just gives you medicine. You don't have to touch it, nothing. We also have these little buttons on there. They look like that. That allow the patient to control some of what they're doing. Now, if there's no continuous and there's just the button, that's called demand only. It's a little more infrequent to do it that way because it's a little bit inconvenient. Because if the patient doesn't press that at kind of regular intervals, then their pain relief goes away. But there are certain reasons to do that. The thing that I use the most that has been found to be the most highest patient satisfaction and probably nursing satisfaction is a combination of the two, called PCEA. That is where you have the patient-controlled epidural analgesia. So you've heard of PCAs, this is PCEA. So I'm going to run a continuous infusion, but I'm also going to give the patient the ability to increase that infusion if I didn't just guess wonderfully at what dose they're going to require. So they can hit the button, they can get a little bit more. I just went over that. Yes, that's what we use here. So monitoring daily, what does that look like from like a nursing standpoint? We do need regular intervals of vital signs, especially blood pressure, because that's really the thing that takes a fall. We are using narcotics, so O2 sats are important. But that doesn't happen super commonly because, again, we're not using a lot of narcotics. So level of sedation, again, for the narcotic stuff, or to kind of assess for a high spinal situation, because you'll get sleepy. Motor function, same sort of reason, making sure we're not getting anything run too high. I say especially of arms, right? I want to see what motor function you have in your arms, because if you don't have good motor function in your arms, then you're going to quit breathing soon. That's where that safety lies. And of course, we're going to assess for pain in regular intervals as well. Let's make sure this thing's working. If it isn't working, call anesthesia. We'll come and look at it and change it and all those things. Anyone with an epidural needs IV access. Period. End of statement. There are no exceptions to this, because if something should go wrong, that's how I save your life, is through that IV. And even that doesn't have wonderful success rates if we run into like toxicity and stuff. But either way, keep an IV in place. The site needs to be checked daily. So rolling the patient or sitting them up or whatever. But you need to look at that site. Look for erythema. Look for bleeding from the site. Does the dressing need to be changed? It usually doesn't, unless it's like just soiled with blood or whatever. Which, just because you're bleeding at the site does not mean you're bleeding in your epidural space. Again, you have a lot of different vessels and stuff. Those are usually in the subcu tissue, and they bleed out, because that's really all. That's your pop-off valve. So that's not a huge issue, but we don't want a patient rolling around in blood. So for the most part, we don't change these for the duration of the epidural. It should be sterile under there. So hopefully we've maintained that type thing. The longest I've left an epidural in, I think, is like 7 days. That's a long time. Here, we usually leave them in for about 2 or 3 days, and then they come out. For these patients, we need immediate access to several things. An ambu bag, if they quit breathing or whatever. We need to be able to resuscitate them that way. Naloxone's a good thing to keep around, because that could help bail them out of a situation. It's usually the local, like I said, but it isn't going to hurt at that point to give them naloxone. And then vasopressors to keep their blood pressure up in any of those situations as well. Here's a real quick way to just assess dermatomal level. People in PACU are probably very well versed in this, but here's kind of how it works. I usually use ice because that's pretty startling. If you can feel, patients will kind of buck up like that. And then you don't have to go around like stabbing them and making them bleed and stuff all up and down their trunk. So you can get some ice, put it in a glove. A lot of times if I'm in the OR, I don't have ice, so I'll take a toe depressor, break it in half, and it usually has little pointy bits that you can use to determine like pinprick level of sensation. If you don't have pinprick sensation, that's one of the first things to go away, and that usually produces like you have good analgesia after that goes away. You may still be able to feel dull, vague, inaccurate feeling, right? I'm pressing here, but I kind of felt like someone's pressing either here, maybe here, you know, that kind of thing. That may still be intact, but that's why you don't just want to touch them there, because they'll be like, oh, I can feel that. You want to make sure it's either hot, cold, or something like a blunt tip needle. The best way to do it is touch an area of normal sensation. I usually use their arm. See how this feels? Ask the patient. Remember how this feels, and then you say like, let me know when it feels the same. And I'll start, if it's a lumbar epidural, I'll start at their hip, and I'll slowly start working my way up, and I'll kind of poke them, until they say, yes, it feels the same. Mark that dermatoma level. Go to the other side, do the same thing. Start somewhere that give them kind of a refresher course of what this is supposed to feel like, and then start where you're definitely numb and start working your way outside of that. If it's a thoracic epidural, start at the level kind of at the epidural. You got to check high and low. Like look at where the epidural or the dermatomal blockade actually exists. So that's kind of how I do it. Make sure you do it on each side of the body. You can have drastically different results, and that's called a one-sided epidural, and those are frustrating as hell because they're hard to fix. I would keep yawning because I'm boring myself at this point, but you've all made it. Good for you. You got through a really long 2-part epidural lecture. You should all be proud of yourselves. Any questions or anything like that right now over any of this stuff?
So if someone has their has it in for several days and you're checking vitals, how frequently are you saying is frequent enough? Like if they're on an inpatient floor and they do them every 4 hours typically.
4 hours should be okay. No, I don't think you need them more often than that, especially if they're stable. Having someone with like a working epidural and then all of a sudden causing issues is not really frequent. A lot of these complications is going to happen in PACU when we start the infusion. That's when we're going to see problems. But never say never. It can definitely happen on the floor. So outside of the inconvenience of the nursing staff, how hard and risky is it to check someone's vitals more often? You know what I mean? It's a very low cost way to double check and make sure everything's fine. You know. Now you can run into hypotension out of nowhere. They've been stable, they've been fine. Now all of a sudden they're hypotensive. So, you know, keep your eye on that type thing. Another good resource is any anesthesiologist ever. So if you're working with one of these things in PACU or on the floor or whatever, and you have questions, get a hold of an anesthesiologist. Call AIC, call whoever's on call, just ask question. I feel like our people are nice enough that they will answer questions for you. Here's a bunch of references you're not going to look at, and I'm done.